due to fatty liver infiltration, not in itself anything more that it causes the liver to look larger than usual. In context, your disease process, because diabetes per se is the ovary, this is the fallopian tube, the same ovary, the fallopian tube. By cutting here, you can actually prevent the egg from being discharged into the fallopian tube. So when the sperm comes here, it stops here, nothing happens. The worst can happen is a spermatocele, which is in itself not a real complication per se of the procedure. However, because of the fact when this procedure was done initially and that portion is cut, as shown in this diagram, sometimes the ends would migrate toward each other and formulate reconstitute that opening of the fallopian tube, and people have been known to get pregnant when they actually had just ligation of the fallopian tube. What was done in the past, what was done subsequent to that, is to create a loop, and then tie that loop so there's no way that will ever reformulate into a tube again. What has been done in addition to that is that the ends have been burnt to such a stage where it's not possible ever for two burnt ends to ever come together and formulate a tube. They may come together very rarely, and if they do, there's no way the passage of an egg, because there's no opening at that stage. So actually, ligation, bilateral tubal ligation has been done in the past, but now it's done at such a stage where it's not only ligated, it's burnt, it's tied. So now if you try and formulate and try and reform that subsequent to having done the procedure, it is almost nigh impossible to do it. In that case, that person will have to have in vitro. You can still get pregnant, but however, it probably might have to be more likely with in vitro fertilization or artificial insemination, in which the sperm is implanted into the uterus itself, and then the pregnancy can take place within the tube. But having pregnancy in a normal way, without harvesting the eggs from the ovum and implanting it into the uterus, is almost nigh impossible. So when you make the decision to have a bilateral tubal ligation, at this point in time, it is almost considered an irreversible procedure. But sometimes the woman and the man comes to me and say, "Doctor, what can he do?" Well, he can do a couple of things, because so far we've not been able to get the pill that suppresses male sperm production. And spermicides, in terms of vaginal inserts of spermicides, have not been an effective method of birth control. Used in conjunction with a condom, it's much more effective. However, there is a method in which you tie the vas deferens, now prevents the production of sperms from the testes itself and being discharged through the vas deferens, going into the posterior aspect of the prostate and into the penis. Now, once you ligate that, the sperm production stops there and it's not able. That is one of the better methods, or male methods, in terms of birth control, by tying the vas deferens. And that is much more commonly done these days. That gentleman, however, can wish goodbye of having another child. I think in our community, it's probably going to be faced with a lot more resistance than in most other communities, because the man is of the understanding, if he ties his tubes, then he basically will have a decreased libido, and that in itself, in addition to the fact that our alcoholic intake and cigarette smoking, will make it even worse, and an increased incidence of diabetes and high cholesterol. So I don't think that will be very popular in our community. We will start a small discussion on what are some of the common signs and symptoms of classic heart disease and pain that's coming from the heart, otherwise known as angina. Angina is, by definition, a pain that's caused from decreased blood supply to the heart itself, to the heart musculature. We all know of the myriads of causes of chest pain, which is sometimes referred to as atypical chest pain. That is a chest pain that is not of cardiac origin. What are those things? Very, very common. Gastroesophageal reflux disease, that we commonly suffer from dyspepsia. Costochondritis, involving inflammation of the junction between the cartilage and the bone. Anything to do with the rest of the chest wall, whether it be involving the outside lining of the lungs itself, the plexus pleural, the internal lining of the lungs itself. So it can be due to pruritic chest pain as well. We can also get chest pain as a result of any of the other organs that basically resulting from the lungs itself, and adhesions between the lung parenchyma and the inside lining of the parietal pleura. But classic chest pain that is due to cardiac origin is angina. Sometimes we describe that as being stable angina, meaning I have to walk up a flight of stairs of over 20 staircases to get to the top of the subway, and that's when my chest pain starts. I can duplicate that same pain the next day by walking the 20 flights of stairs. If I'm able to walk 10 flights of stairs, there's no chest pain. That is considered as being stable angina. I walk 2 blocks before I get my chest pain. That is called stable angina. Unstable angina is when you're not able to predict when your chest pain is going to come on. You're not able to predict the exacerbating and relieving factors. There's another set of complications called Prinzmetal angina, which basically we can get into. But let's stick to the 2 forms of angina that we know of, stable and unstable angina, and try and describe it. What is the role of the EKG? What is it that actually happens that causes us to have angina? Because here again, we're limiting our discussion to chest pain due to cardiac origin. That is the one that's going to give us the heart attack. That's the one that's going to result in us having either the stent or the coronary artery bypass graft for the open heart surgery. That is the one that's going to cause our doctor to alter our medication to become something like Isodil or nitroglycerin to put under the tongue to prevent it. That's when you have established cardiac disease. That is the one that's going to make our physicians say to you, you need to stop the smoking, you need to control your blood sugar levels, you need to continue rapid surveillance, vigorous surveillance of your blood sugar, your blood pressure, your high cholesterol to prevent further coronary artery disease, or else you will end up, or I will end up, with a stent, or worse, end up with sudden death from a coronary event. And how does this occur? Let's look at the anatomy of the heart itself, and most of us will identify this as being the heart. Identify this as being the ascending aorta, and with the 3 biggest branches, the brachiocephalic that supplies the blood supply to the arm and to the up to the neck, the left subclavian that supplies the left side of the arm, the left arm, and the left common carotid that supplies the brain going through to the neck itself. Look at the caliber of the vessels that's supposed to supply the most important organ that is responsible for daily activities, probably with the exception of our brain. And look at the blood supply. And in our population that I have noticed in postmortem specimens, we have much smaller blood vessels than under the average American population, Caucasian and Afro-American population. We recognize this as being the right coronary artery, as it supplies the right ventricle itself and the posterior aspect of the right atrium. We also know the different branches, the marginal branch of it, which supplies that portion over the base of the heart itself. And we know the right coronary artery, the left coronary artery, and the circumflex that goes around it, and then the anterior descending branch and the left anterior descending. They have big names, they have whatever names they have, but what we want to do as we carry on our lives and to continue to provide for those that we love, we make sure that these coronary vessels do not ever become blocked. Or if they become blocked, that it's amenable to a procedure in which you're actually able to bypass that proximal blockage. And as everything else, if we see that there's a blockage on this, let's say for instance there's a blockage, and we went through the etiology, what causes the blockage, the uncontrolled cholesterol, the unstable, the blood sugar levels being high, the cholesterol being high, the blood pressure, and the increased risk that we face as a population of coronary artery disease. And we face with the way in which these arteries become blocked by cholesterol deposits, basically by macrophage, endothelial lining damage, etc., and causes the blockage. However, if it is blocked at this level, then as any plumbing system, there is no blood that's going to the periphery. We do an angiogram and we see that there is a blockage here. And basically that's the blockage that prevents the blood supply from going. Now that blockage is over this area. There is going to be no blood supply to the circumflex and the rest of it. So this muscle now is at increased risk for a coronary event. This is where we get our heart attack. This is where that muscle becomes damaged. Where does angina coming from this? If angina is heart pain, when you have a blockage and it decreases the blood supply to that portion of the heart, then the heart recognizes as a decrease in blood supply to it. It's yearning for the oxygen that comes with it. The way it experiences the decrease in oxygen is by anginal pain. The same way we recognize it in other musculature. A lack of oxygen is going to decrease the metabolism, can increase the amount of lactic acid being produced. But it also, the classic thing to remember, it is going to present with that classic pain, which is called angina. To look at it, the role of the EKG is to recognize that you can find early EKG changes, even on a resting EKG, that we commonly do to show abnormal ST wave changes in this area. And basically that will say to you the ischemic changes. Sometimes at rest you have a normal EKG. Putting you under stress, either in terms of an exercise stress machine, can actually show this much more clearly, because you increase the oxygen demand by exercising, and hence the increased oxygen demand then outstrips that blood supply, because now the heart is beating faster and stronger. And now you recognize that under stressful conditions, meaning 9 minutes of exercise, that you're now having the classic ST wave changes. Now you have ST elevation, T wave inversion. Now you can diagnose that that is definite ischemic changes. However, sometimes when we make that diagnosis, sometimes it's a little bit too late to do anything to alleviate the symptoms. We may end up having either a stent, if we're lucky, or having a coronary artery bypass graft. The most important thing to realize here is that it is a prudent thing if you're at risk, if your family is at risk of coronary artery disease, and all of us are, because I can recognize in this neighborhood that I've been practicing, and the number of families that have heart disease, including my own, that basically makes me much more cognizant that it is something in our community that basically with a high incidence of the diabetes, the high cholesterol, the hypertension, our sedentary habits, our liking for carbohydrate foods that increases the risk factors, our likeness for cigarette smoking, alcoholism, that leads us to these increased incidence of coronary artery disease. We've probably statistically been recognized in a journal as having the population with the highest risk factors of premature heart disease of any population in the United States. It's not a very glorified statistic for us to have. I prefer if we had one of the lowest. But at this point in time, we have one of the highest, and it should be recognized as a population we are at risk for coronary artery disease.